Well, good morning. This is Chair here in Santa Rosa, California, in lovely Sonoma County. And this is my weekly You Are Not Alone. And we are not alone today with Victor McKnight of Risk Strategies. And good morning, afternoon, Vic. How are you today, my man?
I'm doing well. How are you doing, Bill?
I'm doing well.
Mhm.
I've known Vic for quite a number of years. We worked together in San Francisco for a while. He has been one of the leaders in the insurance industry. Risk Strategies, his firm, is the ninth largest brokerage in the United States, $1.5 billion in revenue last year. And they do all kinds of insurance. But the thing I really wanted to talk with you about today, Vic, was as I look at the employer-employee relationships, I would say particularly in the last 10 years, seems to be I guess the word is almost adversarial versus cooperative in many ways. And I know that in the benefits platform, that is one area of concern, attention, and so forth. So I'd like to hear your insight on how you look at that and what are some of the things that employers and employees should be thinking about in regard to insurance.
I think that's a great question, and I think it's a great opportunity for employers to build that relationship with the employees and make them feel that they're walking side by side with them while they navigate the maze of healthcare in the United States. We continue to see costs go up and access be reduced. So employees are having a harder time accessing care in the mental health area, primary care, but almost every aspect of healthcare now is impacted and they're having trouble with access. And then, of course, the cost continues to rise, and there really doesn't seem to be a stopping point anytime soon with healthcare costs.
You
And
know,
so
yeah, exactly what you say, because I keep reading about and looking at the news about, I guess the term is even quagmire of healthcare in the United States. It falls on the employers to take care of the employees. That's a mandate almost by every, state and by the country. And at the same time, the insurance companies seem to be, well, what can we limit ourselves to and provide yet at the same time good service? Uh, how do you see that? Is that going to be something that can be solved at the local level, or is it got to be at a state level, or something more?
I think there's very little local impact. Some larger municipalities have tried to make some inroads. State has limited ability to make changes, but some of them are more aggressive than others. Obviously, we're both sitting in California today, and California does take a very active role
I
in
know they do, yes.
healthcare,
Mhm.
and sometimes that may be helpful to some, harmful to others. It may increase or decrease costs, but really the ball lands in the court of the federal government, and they have the most ability to make changes. As you know, we all have lived through
Mhm.
the implementation of the Affordable Care Act or Obamacare, and that had some areas where they really help the marketplace or employers or employees. And there's other areas where they really caused some challenges for all of those.
Mhm.
So there was both going on at the same time, but it definitely was one of the biggest revolutions in healthcare in my lifetime for sure.
And the new administration seems to be trying to address some of these issues, and there's all kinds of conversations and new healthcare, leadership within the new administration. What is your ideal client, and what do they look like, and what do you recommend as a starting point for conversation?
So in Sonoma County, we have plenty of clients that have 20, 25 employees, family-run businesses, and we love to work with them just because those are our neighbors and our friends.
It's
But
like
I
the
think,
sweet spot for our Vistage membership as well.
oh, really? But I think our sweet spot actually is really 50 to about 1,000 employees. What we're
Oh, really?
seeing
Up to 1,000.
is,
Mhm.
yeah, the marketplace in health insurance is split into two big categories. Under 100 employees, it's very cookie cutter. And it's and the rates are really based on age and the plan that you choose and the carrier you choose. So it's very cookie cutter. There are some areas where we've been able to save companies money, looking at different HRAs or medical expense reimbursements, gap plans. We won't go into all of those, but there are some areas where we can definitely bring down costs or increase benefits. But once you get over 100, there's both risk and opportunity for employers. And that's where we can really make some huge impacts.
Yeah, yeah,
I
yeah. Give an example of like, you got 150 employees, 200, and what are some of the negotiations or considerations I can give for my employees that save me money and also at the same time provide better benefit for them?
Yeah, well, let me talk about the risks a little bit, and I'll
Okay.
talk about the opportunities. We had once you get over 100, the carriers really have the ability to increase rates to whatever they want to, whatever they deem to be necessary for them to make money.
And rates have been
Um,
going up, as you said earlier.
yeah, the trend on rate increases is high single digits. We're seeing a majority in low double digits, so 12, 13%.
And
Though we
my
were
question is, why do you see that raising or rising, the raise in rates? What is causing that?
think there's two big areas. Costs are going up for healthcare. They're going up as far as large claims and hospitalizations. So
Hmm.
so we're seeing $1 million claims were fairly rare at one time,
Hmm.
where we would see one member of an employer have $1 million worth of healthcare. It's coming much less common now. So we're seeing that more often, which is increasing costs. And then prescription drugs, the drug companies, they
Hmm.
have a lot of influence in Washington, D.C. And
The lobby is very large, yes.
yeah, they're the largest lobbyists in Washington, D.C., and have
I did not
incredible
know that. Yeah, the
influence,
largest.
re regardless
Yeah.
of if you're on the donkey side or the elephant side. They're very influential in both areas. So we're seeing a lot of challenges, and they're coming out in their defense with some great, incredible drugs that can only treat a certain small segment of the population. So, but what that allows them to do is really get a blank check for employers and employees through the insurance system to have the cost passed on. And what we have to realize is when costs go up, it's really part of every employee's paycheck.
Explain that walk through there. I'd be kind of curious to follow that line a little bit, if it's
So,
okay, if you are comfortable
so
doing that.
sure. They come out with a new drug that is great for this one childhood illness, and they set the price. And and if that drug is such that it's going to do something that no other drug is going to do,
Mhm.
insurance carriers are somewhat required to cover that.
Yeah, the last two
And
years, for example, the weight loss drugs.
yeah, in the weight loss drugs, there has been some ability for health plans to say no. My
Oh, really?
company does not cover it.
Hmm.
And by the way, we're going through a major change in the weight loss drugs. Up until now, there's been a shortage in the United States, which has allowed companies like Hims, Roe, and MD to produce this as a compound, basically as a generic is the best way to think about it, and sell it for between $200 and $300 per month per member.
Mm.
That one's going away in either April or May, to where now because the shortage has been declared over, and so those companies are going to be forced one way or another to stop making it, and the price is going to probably go up to about you have to buy it directly from the provider, from the drug company, and it's going to be about $499 per month
Oh
now.
my goodness.
So members are going to have to decide to buy the real stuff. That's the good news, but it's going to be a lot more expensive. We'll see what happens with supply and demand, because this is going to be a true supply and demand situation. Because what will the drug companies do is some decide to pay the $500, or some members decide not to.
Yeah, it's a classic, I would say, conundrum that
Sure.
a pharmaceutical or drug company goes through to spend the money, develop the research, and so forth, then comes out and maybe they spent years in developing it, but now they want to get paid, and then the people that suffer from whatever illness or
Yeah.
malady want to pay less, and then the government gets involved. What a no wonder they have such a huge lobby.
Well, yeah, they never would have had the opportunity for these companies to make it on the side if it
Hmm.
wasn't for the fact that they couldn't produce it fast enough. Because when we figured out that we could take this stuff for a weight loss, instead it was invented for diabetes. And when individuals figured out they could take this stuff and lose the weight that they've been trying to lose for years, and there's a real positive in this, right?
Hmm.
Heart disease is
Oh
is
yeah,
one of the
one of
leading
the biggest
cost
killers. Yeah.
drivers, and so obesity is obviously a driver to that. So as we reduce, last year was the first year the United States in decades had a decrease in obesity in our country, and it's pretty much pegged to these weight loss drugs. So
Amazing.
it'll be interesting, as I said, to see what the supply and demand looks like,
Mhm.
how many people stop taking it, and the effects, unfortunately, when people stop taking this is they typically gain a good portion of the weight back unless they do some major lifestyle.
Yeah,
Um,
that's one of the rubs and oftentimes treatments is that it's a lifetime treatment. It's not something that cures the problem. It's something you have to do in
yeah.
perpetuity. It doesn't
But
really
back
stop.
to the
Yeah.
back to the cost issue,
Mhm.
we have a client that's got about 125 employees. So they're just outside that range of getting the rates that are everybody else gets at, in for that plan. So Kaiser this year said that they had lost some money on this group 3 years in a row. And it was due to, we think, only one individual that had a high cost claimant.
Oh my.
So this group had about
And
80.
one company you're talking about.
I'm talking about one company here in Sonoma
Yeah.
County had about
Wow.
75 to 80 employees on Kaiser, and they got a 50% increase. That's 50, not 15. That's a 50% increase this year. And we're working through this with the employer. But I called up the employer when I got the renewal, and I said, "Hey, I got to stop by and talk to you." I wasn't going to deliver that one over the
No,
phone.
absolutely
And
not.
we created a plan to address that. And one of the possibilities is we very well may terminate Kaiser and go to a different type of insurance product.
Mhm.
This company may actually look at a self-funded product
Tell us about
where,
self-funding. How many of your clients do that? It seems like kind of expensive in a way, and maybe you don't cover as much as you need to cover.
I would say I would disagree on both of those counts. I
Okay.
think there's a
There you go.
possibility
That's
of
why we're talking to the expert here.
Yeah, there's a
Night.
possibility of decreasing cost and actually improving and more personalizing the delivery of healthcare. And really, what we're doing now is we're looking at changing the way we deliver the healthcare. For one, it's going away from an HMO, which has
Mhm.
more control over access, to a PPO product. And normally, what we do is
Explain those two terms. I hear them HMO, PPO. What is the difference?
Kaiser's your largest HMO, but Sutter and has their HMO called Sutter Health Plan, and
Hmm.
just about all the carriers have HMOs. But that's where the employee choose a primary care physician, and that primary care physician is typically part of a medical group, and will
Right.
direct that care into specialists within that medical group, and will have a little bit more control on the healthcare. PPO plans typically are more expensive, but not always.
Hmm.
Um, but there's more freedom. And there's typically a little more out of cost when you utilize the plan.
Hmm.
But for me on my PPO plan that happens to be self-funded, I could go to Stanford tomorrow to see an orthopedic surgeon or a cancer specialist if I needed to,
Hmm.
without asking my primary care physician for a referral. So that's
Interesting.
one of your benefits on a PPO. And
Mhm.
typically in self-funded, we will choose a network that you're familiar with already. One of the big, we call them BUCAs, the
Mhm.
Blue Cross, the Blue Shield,
Mhm.
Anthem, United, Aetna, those types of plans, Cigna. So we'll choose one of those networks, and we'll rent them. So we'll basically pay them a fee to access their discounts. We'll buy a stop loss. So in case anybody has any really large claims, there's an insurance company that's going to come in and support that, maybe over
Kind of like a reinsurance in a way.
A reinsurance, anything over, for a group the size that I was talking about, that stop loss may be 50,000 per employee. And then we'll buy aggregate stop loss, which is maybe they're spending $1 million. But if they get small claims in excess of, let's say, 1.1 million, the insurance company is going to kick in and pay that claim as well. So there's still protections. There is more exposure for the employer. There's definitely some risk. But then what we're able to do is really address some of the cost drivers. We're able to look at pharmacy benefit managers and have access to some of the large rebates that the drug companies are providing the pharmacy benefit managers.
That's one area that's always been a little bit of a mystery to me. What is a pharmacy benefit manager, and how do I benefit, or how does the company benefit by having that individual or that company involved? What do they actually do?
Benefit would be maybe a challenging conversation. So some of the largest are owned by the healthcare companies. In fact, United Healthcare, which is the largest provider of health insurance in our country, owns Optum. And if you watch the golf tournament this week,
Optum just today,
they were all over the Rory McIlroy is a spokesperson for it. They were all over the big golf tournament that was this week. Optum
that's where I saw it, I believe.
All over the place.
The
and they're the pharmacy benefit manager that's owned by United, but they also contract with other organizations. And in one year recently, Optum created more income than the United Healthcare health insurance company. There was more income at Optum.
So their partner or subsidiary created more income than the parent.
Exactly. And so they're basically a middleman between the drug companies, the health insurance carriers, and the employers and members.
What do they actually deliver?
Well, if I was representing them, I would tell you that we're going to drive discounts. We're going to manage the experience for the employee and make sure that employees are receiving the drugs that are appropriate for them. So, for instance, if somebody wants to lose 10 pounds and they want Ozempic or Wegovy to do that, we're going to decline that, because we're going to check into it a little bit and say, no, that's not an appropriate reason. So they're going to manage that process, and they're going to make sure that they get the rebates driven down to typically the health insurance carrier. Now, in a self-funded plan, that is the actual employer. So one of the ways
so the pharmacy benefit provider in a self-funded plan is not part of the equation, it's the employer.
Well, we still hire, like in a self-funded arrangement, we still absolutely use a pharmacy benefit manager, but we use one that's independent of the insurance carriers and are completely transparent, meaning every rebate dollar goes back to the employer, back to the plan, which is the employer.
Hugely beneficial situation. I can understand now why maybe the self-funded approach keeps you out of a system that might be quite convoluted
and adversarial at times, and puts you on the same side, and they become on the same side as the employer. There's also other opportunities that they have where they can aggressively maybe purchase drugs offshore. So, and when I say offshore, I'm talking about Canada, Australia, and Great Britain. We're not going to a third world country. We're going to Canada or something like that to access drugs and drive down the cost. And this is a way that we're able to further drive costs. And then managing healthcare, bringing in specialists. So if you get diagnosed with cancer, you have the best opportunity to survive that. I had one friend who represents a captive, which is a form of self-funding where you actually partner with other employers to reduce the risk even more by partnering with them and bringing on opportunities that if you're just on a standalone basis, you might not have.
I've heard that term captive insurance, and it seems to be more and more common these days as
it
people
is.
tell us a little bit about the captive concept.
The captive concept on the benefit side is that you're oftentimes you own the insurance company, and or a piece of the insurance company, and you're going to be part of that captive. Let's say I call it the Vic captive, named after you and I, who started it, right? And so we take that, we start that, and we might we're going to talk to organizations that want to drive down costs, and they can jump into this captive, and they're going to get discounts for their stop loss insurance, maybe on their third party administrator who's going to pay all these claims. And the renting of the networks, they may get discounts for those, and then they're able to bring in programs like a PBM that's completely transparent. They're going to be able to bring in a company like a Cancer Care, which is going to manage their cancer patients, not only on a cost, but quality of care. As I was saying, a friend of mine that works for a captive, his wife was diagnosed, and he loves to tell this story because he got some really bad advice from the first doctor, called Cancer Care that his company contracted with. They stepped in, made sure he had the best care, and he feels saved her life. It actually probably drove down costs for the health plan, which is secondary. Yeah, and he got to walk through that and see it in a much more emotional way, and he tells that story, and it's compelling. So if I was to go self-funded on a 150 life group, you probably can't afford to buy Cancer Care. It's going to be pretty expensive. Right. But because inside the captive, they have access to all the members, there's a shared cost to it. And sometimes it's a menu where companies can choose to purchase it, and sometimes it comes with the captive. And but in the long run, we're able to get to be a bigger part of the healthcare equation, and hopefully, like I said, improve care while driving costs down. You're not going to, we're not going to reduce the cost 50%, but if we can reduce the trend by from 9% to 3%, that's a significant difference. And your original question was about the employer-employee relationship. If we can help the employee feel that employers are on their side in this area,
which is critical. I think
it's critical, and also keep the costs down so employees can actually afford to put their dependents on the plan, for instance. That's a really difficult area for a lot of employers or employees. How do I, there's only so many pennies in a dollar. I think it's 100 last time I checked. And if they, can they afford to cover their 2 children on their health plan?
And of course, the pennies are disappearing as well. So soon it's going to be just nickels in a dollar.
True.
Yeah. Again, back to your ideal client, and you come through and you speak to the C-suite, you're talking to the CEO, you've got 200 employees, roughly, here in Sonoma County, large manufacturing company, great reputation. They've got a healthcare plan, they need to make a change. How would you present to the group? What would you come in and say to the C-suite, the CEO, and then have a meeting with the employees to maybe roll out something? Would it be the captive approach, or what would it be?
Could be. It depends. It really depends if it's appropriate for the client. And that's a pretty broad question without knowing details. But what our conversations typically start with the CFO, the head of the HR department, the CEO, and get where they're at now. Too oftentimes, employers have been taught to purchase where a broker comes out, presents what they have now, becomes the starting point every single year. And then what do? Well, there's 3 levers to press. We can ask the employees to pay more in their paycheck. more when they see the doctor, or have the employer pick up the added cost. Those are the three levers. And which ones are we going to pull this year? And we try to change that conversation around and really get more like, what do we want to do here? What is a deal breaker? Could we get rid of one of your HMOs? Are you married to it? If we are able to really change the landscape of your health plan and the costs, could we do that with your company? How difficult would that be? Last year at open enrollment for one of my large employers here in Sonoma County, we warned the employees, most likely this is the last year you're going to have access to Kaiser, because we're going to go to this captive. We're going to get involved more in our health care. We care about you and we care about the care that you get. But in order to do that effectively, we may need to unload Kaiser. And so Kaiser's on notice that they very well may be terminated next year. That's going to be a difficult scenario for these employees, but we've already in discussion with providers here in Sonoma County where they're ready to take them on. Which ones? They have a Spanish-speaking population that, frankly, Kaiser's really good at serving. Are we willing to how can we serve those clients, those members? And this company really cares deeply. Everything they do screams, we care about our employees, we care about the community, we care about the environment. They are an incredible organization, but they see the challenges with the current healthcare system.
I really like that approach personally, from a standpoint of like it's company bottom up driven, up to find care, versus top down driven. Here's what we have, here's what you get, versus here's what we need, where can we find it? And
Exactly.
I seems like that approach.
Yeah. How do we cut
The employee get more involved in their healthcare decisions versus saying, well, you've got to go to whatever, that's the only choice you have.
Yeah.
Let's make something else that maybe involves you and taking care of yourself better. I would think for a CEO, an HR department, and a company, that would show more care that you're delivering.
That's our goal.
Yeah. And most of your clients, would you say, Vic, are in that category or a mix?
I think everybody yes, I think employers are looking to do something different, to give me something different out there that we can. How do I slow down this cost increase? Maybe I'm happy with where my employees access care. They're fairly happy with that. But how do we stop the cost issue? And we haven't talked much about access, and I'd like to address that.
Absolutely.
Because that is right now, it is a huge problem. Over the last 3 to 5 years, I've had more calls than ever about I've got insurance, I just can't get in to see a doctor.
Oh, I hear it a lot. Yes.
Yeah. Primary, mental health is a big one. We removed the stigma of mental health, which is a huge win for society, but we didn't train enough people to help the patients. Primary care is number 2. It is a losing proposition for most physicians to go to medical school and become a primary care physician because the pay just a bad equation.
I have several doctors that are friends that talk about that while that 10, 15, 20, 30 years ago was a wonderful calling to be a doctor in that, and many people sought that, the regulations and all the other problems right now does not make it a very desirable career.
Not especially in the primary care realm, the general practitioner, the family practice. It just doesn't make sense financially to spend as much money as it takes to get through medical school and then to actually go into practice. So that's going to continue to be a real issue. And then even the specialists, most of the doctors are getting close to retirement, and we have not been creating enough doctors. So I think we're going to probably have to do a lot of different programs to address this. I have a feeling some will be immigration driven. We'll be stealing doctors from other countries.
Really?
I do. I do. And teledoc is a very popular, there are a lot of things where I
Hmm.
can I can buzz into a doctor in an area that does have enough physicians and get treated that way. I think that's going to be
Yeah,
an
it really exploded during COVID.
it did. And that's a good thing. It doesn't solve all issues. It's creates some problems where it solves some others, but it's got to be part of the equation.
Mm-hmm.
And then nurse practitioners and really using other medical professionals to deal with issues that you really don't need an MD on. If I think my grandchild has um, a, a strep throat, I can't go in. I don't need to go see an MD to get a strep test.
Right, exactly. Exactly.
So I think there's some areas around that we have to embrace.
Well, let's say it's my enrollment period is up, and I reach out to Vic McKnight, and I'd say, Vic, I need you to come in and talk to my HR department and to me. You know, here's our plan. We've got an HMO, we've been using for years and years, and we've worked at it, but we seem to be having some access problems. What would you recommend, and what would you say to me and to the HR department, and then maybe even present to the employees?
So if you're 15 or 20 employees, yeah, doing it at the enrollment period, it could be fine. If you're a larger organization, you want to start this process and this conversation 6 months out
Oh,
to
really?
really get a full analysis. And what I would do first is ask for, what are you doing now?
Hmm.
What's working and what's not working? So show me your health plan. Tell me what you're charging your employees. What do your benefits look like? How do you communicate the benefits to your employees? That's a huge area.
Oh,
If I think a lot of employers are not communicating their benefits to their employees in a way that are they customizing their benefits um, summaries so the employees can access what they need, bring something home, or
hmm.
provide something electronically to their spouse who might be the person driving the healthcare
Oh,
in the
yes.
home.
Hmm.
So that would be one is where are you at now? Getting a real good feel and a conversation on where you're at, and then look at opportunities to make changes, and not only making changes this year, but what's our 3 to 5 year plan?
Oh, great question. Exactly. Longer term outreach. How many employees do you envision having in 5 years from now?
And yeah, what can we do something right? Could we get rid of that one health plan right now, or could we
Hmm.
change benefits today as much as we'd like to? Maybe not. Maybe we'd feel like we'd lose employees or whatever.
Hmm.
But how do we educate people over a 3 to 5 year period and get to where we want to go? It's oftentimes the second highest cost on your P&L statement. You got
Wow.
salaries and then benefits.
Wow.
And
True. Yeah.
why are we making decisions in a 90-day period of time right before your renewal on such a large cost?
Yeah, we have to make this decision in 90 days, and the impact on our bottom line could be quite meaningful.
Yeah.
So a
And
better leadership would say, let's, engage with risk strategies, Vic McKnight, 6 months before we do this, so we know what we're facing.
exactly.
How do we get in touch with you, Vic?
Well, my email address is vmcknight at risk-strategies.com. You can give me a call. You can connect with me on LinkedIn. I'm somewhat active on LinkedIn,
I've
so
seen you.
find me there.
Hmm.
Or just give me a call. You can Google me, it comes up pretty easy.
That is fantastic. And Vic, I can't thank you enough for your time and a very complicated and involved subject. And experts like yourself are critical to business owners and leaders in Sonoma County and really all over the Bay Area and knowing how to deal with this complicated issue. So we appreciate you being with us. So we're not alone today. We're with Vic McKnight. And Vic, we will talk to you soon. And hopefully your phone and your emails will start lighting up and saying, I need to talk to Vic McKnight and figure out
Well,
what.
thank you for the leadership that you provide in our business community and for doing this and giving the opportunity to be here. I've really enjoyed it.
It's my pleasure. Thanks so
All
much.
right.
Appreciate
Thank
it.
you, Bill. Talk to you
Okay.
soon.